A very good afternoon to one and all. So we keep talking about our success stories before procedure, after procedure and everything, and now we have come to a level where we are accepting and acknowledging failures in OT. So let us see how God saved my day. This is a 66-year-old female, diabetic, hypertensive, known case of chronic kidney disease. She was admitted outside at a local hospital for fluid overload. She was intubated, recovered, and she was discharged. She came to our center for hemodialysis, and then the nephrologist did a CT scan to evaluate her breathlessness, and this is what he saw. And he referred us for EBUS because the report said that there are necrotic lymph nodes in the mediastinum. At this point of time, I request for a show of hands at the audience and also comments from the chairpersons. How many of you would make a pass, EBUS pass in this lymph node? Chronic kidney disease, tuberculosis is definitely a possibility. Anyone who would say that definitely I would make a pass? I can see some of you shaking your heads like this. Okay. So it's very important to follow stepwise protocol. So we started with the white light bronchoscopy here. So white light bronchoscopy always before EBUS. We can see that the posterior wall is erythematous, pathological. It is not very usual. Any experience from anyone with similar kind of findings? So as this part of the bronchial tree looked abnormal, we started screening for the lymph nodes with EBUS. And again, stepwise protocol, we always need to put Doppler before making a pass into the lymph node. Even though it looked like a coagulation necrosis sign, we can see the swirl inside. And when we put the Doppler, we could see that there was vascularity inside. So at this point of time, we also have to decide at one point when not to do procedure also, even though patient is intubated and we have already started. So we abandoned the procedure. And then after discussion with the nephrologist, we went ahead with contrast CT. This is how the contrast CT looked like. Any comments? So this was right brachiocephalic artery with multiple partially thrombosed aneurysm. So we can see here that there is aneurysmal dilatation. So after this, we were more curious regarding the findings and also why aneurysm in this patient. We took a detailed history and multiple pricks were made while central line insertion in the ICU in the outside hospital. So we feel the aneurysmal dilatation is because of the multiple pricks and a false track that was created that led to the aneurysmal dilatation of the vessels there. So literally God saved our day because we didn't pass and we went through stepwise protocol, white light bronchoscopy and also putting Doppler before passing the lymph node. Any similar experiences or any comments from the chairpersons?
I think the case is really, really good because it highlights the importance of contrast media when doing CT scans. It highlights the importance of contrast media when doing CT scans. There's several reports in Germany as well of lesions that looked like tumors, but it ended up being a vessel malformation. Unfortunately, the colleagues did the biopsy thinking it is a tumor, but it ended up having a large bleeding complication, which was managed with surgery. But this highlights that as well, that before doing any biopsy, depending on the kidney function as well, it's still very important to always have a contrast media CT before doing a punctures because vessel malformation is a very common finding in CT scans, which otherwise get missed. Has anyone had an accidental vessel puncture in the audience? No risk, no fun, apparently. What do you say?
Yeah, I think to keep up one more watch about Delorphis anomalies is also one more thing actually. We just see that mucosal hyperemia can be part of a Delorphis anomaly also, where we enthusiastic to do a biopsy, that can also have a nightmares in terms of excruciating bleeding, all this stuff could be a possibility. That is also a word of caution which has to be kept in mind. I think Doppler is also one more helpful tool to put in a needle, before needle actually. Doppler is also a good practice to do. As you rightly mentioned, that contrast CT is always a thing when you are in a DISE, when somebody who's having a chronic kidney disease with platelet dysfunction is always going to be a nightmare actually when they starts bleeding. So precautions, stick to the basics is the need of the hour actually, what this case enumerates.
So like the chairpersons rightly said, CKD platelet dysfunction also, and again stressing upon the stepwise checklist of the procedures. So I'll leave it to imagination of all of you what would have happened if we had made the pass. Thank you.